Welcome everyone. I am Aseel Malik, third medical student at the Musa University. Our seminar is about the grievous disease, supervised by Dr. Zahraa Marwan. Before we start our subject, it is important to remember some general basic about the thyroid gland. Thyroid gland, it is a butterfly shape that is located in the lower front of the neck. And this gland releases the most important hormone in the body, T3 and T4. These hormones help the body use energy, stay warm, and keep the brain, heart, muscle, and other organs working in the correct way. And just a brief background about the pathway of secretion of the thyroid hormone. Start in the hypothalamus. That is release the TRH, thyrotropin releasing hormone, which acts on the anterior pituitary gland to release thyroid stimulation hormone. This hormone travels to the thyroid gland to release thyroid hormone T3 and T4. This hormone actually has a negative feedback on the hypothalamus and the anterior pituitary gland. Keep in your mind, any disturbance in this pathway will lead to specific disease. And now it is the time to talk about our subject. What is the grievous disease? It is autoimmune disease that is lead to overactivity of the thyroid gland and considered the most common cause of hyperthyroidism. The first one who described it, Dr. Robert Gravius, and it's more common in young female between the age 20 to 40 years. And now what is the factors that lead to Graves' disease? We have many factors. The first one, genetic factors. A family history of the Graves' disease increases the chance for this condition. The second one, if we have another autoimmune disease like Hashimoto's or another one, maybe see the Graves' disease with it. The last one, environmental factors. For example, individual under emotional and physical stress, infection, pregnant women, smoking, iodine deficiency. What is the pathogenesis or the mechanism that is lead to the Graves' disease? In Graves' disease, we have antibody called thyrotropin receptor antibody TRAB or thyroid stimulating immunoglobulin TSI. This antibody bind to the TSH receptor that is found in the surface of the thyroid cell and lead those cells to overproduce and release thyroid hormone and reduce the activity of TSH hormone on the cell. How can this antibody cause the exothalamus consider the main specific symptoms in the Graves' disease? This antibody may also target TSH receptor on the surface of the fibroblast and adipocyte that's found behind the eye, so lead to activate it and release hydrophilic glycosaminoglycan which accumulated in the extraocular muscle and retroocular tissue, along with excess fluid leading to swelling and bulging of the eye. Thank you for listening, and now my colleague Elaf will continue.
Assalamu alaikum. I am Elaf Ali. I will continue with the morphology. Grossly, the thyroid gland is usually symmetrically enlarged due to diffuse hypertrophy and hyperplasia of the thyroid follicular epithelial cells. On cut section, the parenchyma has a soft, meaty appearance resembling muscle. Histologically, the follicular epithelial cells in untreated cases are tall and more crowded than usual. This crowding often results in the formation of small papillae, which project into the follicular lumen and encroach on the colloid, sometimes filling the follicles. The picture on the right side shows the small papillae project into the lumen, so we see the lumen narrower in comparison to the picture on the left side, which show the normal histological appearance of the thyroid gland. Also under the microscope we can see T cell, B cell, and macroplasma cell in the interstitium. And also germinal centers are common. After we know what's the Graves' disease, we will speak about the sign and symptom of it. We have specific and non-specific symptom. The non-specific is similar to symptom of thyrotoxicosis. The most common one is goiter, tachycardia, palpitation, insomnia, irritability, tremor. Fine distal tremor is an almost universal finding. Related to GIT, increased appetite associated with weight loss due to catabolism, atrophic gastritis and/or celiac disease of autoimmune origin, heat intolerance, fatigue, dyspnea, sweating. By all these symptoms, we can't say that's a Graves' disease because it is a general symptom. So, it's about specific symptom. We have two, exophthalmos and peritibial myxedema. Exophthalmos is an abnormal protrusion of the eyeball from its socket, induced by retroorbital edema and fat deposition, as we see in the picture. May be unilateral or bilateral. It is commonly asymmetrical. The second is peritibial myxedema, as a puzzling manifestation of the skin, characterized by a non-pitting swelling of the peritibial area, brownish and reddish in color. This manifestation is relatively rare in patients with Graves' disease and is almost observed only when Graves' ophthalmopathy is also present. That's to say, ophthalmopathy will appear first and then peritibial myxedema, not the opposite. Swelling may occur due to subdermal mucinous deposits. We can observe this feature on other areas like hand and forearm. Exophthalmos and peritibial myxedema symptoms of Graves' disease are due to the autoimmune component of the disorder rather than the hyperthyroidism. The onset of symptoms is usually gradual over a period of weeks to months, and in some cases mild symptoms can exist for years before the diagnosis is made. So, what's about the diagnosis? We have 3 steps: physical examination, laboratory evaluation, and imaging studies. Physical examination, we will mention to the most common organ affected by Graves' disease, thyroid and eye. We will examine the thyroid to assess enlargement in size by palpating the gland. In the eye, we will see exophthalmos. Clinically, exophthalmos can be recognized by the presence of the sclera between the lower border of the iris and the upper margin of the lower eyelid. Second step, laboratory evaluation. TSH will decrease. Total T4 or free T4 to determine thyroid function will increase. T3 to help determine the severity of the hyperthyroidism also will increase. Complete blood count may be checked prior to initiating antithyroid medication. When the diagnosis of Graves' disease is inconclusive, the doctor may order 2 additional tests: thyroid peroxidase antibody and thyroid stimulating immunoglobulin. TPA are high in approximately 75% of Graves' disease patients. If symptoms of Graves' ophthalmopathy are present and the blood tests for Graves' disease are positive, there is usually no need for further testing to confirm a diagnosis. But in other cases, if hormone levels are normal, but symptoms of Graves' ophthalmopathy are present, the doctor may choose to do imaging studies: radioactive iodine uptake, CT scan, ultrasound, or MRI. A high radioactive uptake is typically characteristic of Graves' disease, but low uptake may point to a viral infection or other inflammatory condition of the thyroid gland. MRI to look for characteristic swelling and increased retroorbital fat that are associated with the Graves' ophthalmopathy. Treatment. We have 3 types of treatment: antithyroid drugs, surgery, and radioactive iodine. The surgery is only considered in cases where the treatment with antithyroid drug has failed or where there is a large goiter. Radioactive iodine. This treatment is not commonly used in young people or women of childbearing age due to the fear of teratogenic and carcinogenic effects. In summary, Graves' disease is an autoimmune hyperthyroidism. Exophthalmos, peritibial myxedema is the most helpful symptom in establishing the correct diagnosis. We will measure TSH, T4, and T3. About the treatment, we have antithyroid drugs, radioactive iodine, and surgery. These are our references. That's all. Thank you so much for your listen. If you have any question, feel free to ask in the comments.